I'll be presenting a case with a patient named XYZ. Am I audible, ma'am?
Yes, yes. You're audible.
Patient named XYZ, 68-year-old male. He was a postman by occupation. He was a resident of Haveri. Then he was admitted on 18th December 2020. He was examined on 21st December. He's a right-handed person and informant being self and self and the son, and the history is reliable. Coming to the presenting complaint, he came with complaints of progressive weakness of both the lower limb since 4 years and progressive weakness of both the upper limb since 2 years. And he complained of wasting of both the upper limbs since 1 year. Coming to the history of presenting illness, patient was apparently in his usual state of his health 4 years ago. Then he noticed weakness of both the lower limbs. Initially noticed difficulty in raising his leg up while mounting onto the bicycle and pedaling. He's a retired postman. Before he used to go with the bicycle and distribute the post. He has difficulty in placing his foot over the bicycle. This was the initial complaint which he noticed, which was 4 years ago. Later, he had difficulty in climbing up the stairs and difficulty in getting up from the chair. His weakness was progressive in nature, that such that since 1 year, he needs help of another person to make him get up from the chair and make stand. And since 2 years, he has difficulty in gripping his chappals. He also noticed difficulty in raising his arms above the head. He has difficulty in reaching for objects like files and papers placed in the upper shelves. He has difficulty in taking head bath and pouring water above his head. Difficulty in reaching his hand above to comb his hairs. Since 1 year, he has noticed gradual wasting of his arms and thinning of the. He says that the thinning of the muscles on the right side is more compared to that on the left side. He complains of gradual difficulty in holding objects in his hand, like difficulty in holding or gripping a spoon or pen. He has difficulty in mixing food, difficulty in opening the bottle cap. He is not able to hold any objects in his hands, like holding a cup of coffee or holding a newspaper. He has difficulty in buttoning and unbuttoning. He says that he can't even pull the bedsheet on his body. Since 2 years, he complains of difficulty in turning on the bed from side to side and difficulty getting up from lying down position to sitting position. Since 6 months, he has noticed the difficulty in lifting his head up above the pillow. He says that his head droops when he is continuously sitting and watching television by sitting on a chair, and hence he started using a neck collar for support. He says that the weakness is gradually progressive and there is no fluctuation in the weakness and no triggering factors. There is no history of pain in the muscle or pulling sensation over the muscles, and no history of muscle cramps and no history of tremors. He can easily differentiate between hot and cold sensation while bathing, and he feels the touch of his clothes over his body. He says he has no memory disturbances, and his son also says that he can actively remember the things. He can see and look around in all directions. There is no blurring of vision. He has no complaints of swelling or mass in the back. There is no numbness or tingling sensation, no feeling of walking over the cotton wool, no history of drooping of the eyelids, no difficulty in chewing, no difficulty in swallowing, no history of dysarthria, no history of double vision, no history of change in voice, no history of bowel bladder incontinence, no history of altered bowel habits, no passage of cola-colored or coca-colored urine, no hearing difficulty, no history of imbalance or swaying while walking, no joint pains, no history of falls, no history of rashes or no cutaneous lesion, no history of cutaneous lesions, no history of high-risk behavior, no history of trauma, headache, no history of loss of consciousness or seizures, no history of morning headaches, nocturnal arousals, no excessive daytime sleepiness, no difficulty in breathing or orthopnea, no palpitations or chest pain, no history of mass per abdomen. Past history, he is a known case of hypertension since 6 years on treatment. He is on Telma 40 mg OD in the morning. He has taken Ayurvedic massage treatment for the same muscle weakness since 1 year. He was on some homeopathic treatment for the muscle weakness. Personal history, he follows a vegetarian diet. His bowel bladder habits are regular, no sleep disturbances, normal appetite, non-smoker, non-alcoholic, no history of loss of weight or loss of appetite. family history is born out of a third degree consanguineous marriage. He has 6 siblings. He is the third child. There is no history of similar complaints in any of the family members, like usage of wheelchair or any weakness among the family members. In order to summarize, 67-year-old gentleman, hypertensive, he presented with progressive weakness of both the lower limbs, proximal more than distal, and progressive weakness of the both upper limbs, proximal more than distal, with involvement of the trunk and neck muscles. There is no sensory involvement, no sphincter disturbances, and no cognitive decline.
Okay. We'll start analyzing the symptoms. No? First symptom, you said that he had difficulty in lifting his leg and putting it on the other side of the vehicle, which he wanted to pedal. No?
Yes, ma'am. Yes, ma'am.
Would you like to analyze that symptom? Where do you want to put that? Did he have any pain, any joint stiffness, limitation of movement?
No, ma'am. No limitation of movement, no. Yes, ma'am. He's a 68-year-old. It is not, it's painless, ma'am.
So painless
he did not complain. Yes, painless difficulty. There is no joint pain. Initially, it was difficult in lifting his leg up, and getting up from the chair. So the proximal muscles of the lower limb.
So first thing you told, he has difficulty in putting his leg on the opposite side of the vehicle to balance.
Yes, ma'am.
So what is that
movement?
So it is painless. 68-year-old postman walking long distance. We will have to consider osteoarthritis of the hip joint and all those things. So it is painless, so very unlikely to be mechanical components of the leg or getting involved. So it is, what is that movement? Abduction. No?
Abduction.
So to lift the leg and put it on the other side of the cycle, you said, that is abduction. So what is affected initially is abduction. So what is the abductor structure? Which is the
hip gluteus medius and gluteus minimus, the hip abductors are involved.
So the first muscle to be involved in this patient, first movement involved is carried out by the hip abductors. So it started on both sides symmetrically. So it is definitely not due to the mechanical.
Initially it started.
Tell. Initially it started where?
Initially he said it started in the right upper limb. Sorry, no, right thigh was not able to. Right lower limb, and later after 3-4 months he noticed in the left side.
Okay, mild asymmetry between the right and the left, 3 months. In the right side also it is lifting and putting it on the other side of the vehicle only, or any other power. What you said is like that, raising the leg and putting it on the other side of the vehicle.
He has the same difficulty. Yes, ma'am.
So if it is symmetrical, what does it implicate? If it is asymmetrical, what does it indicate? So if we started symmetrically, let us imagine that abductor weakness started symmetrically on both sides, and let us imagine it is purely motor. So abductor is a muscle. So the disease can be from the muscle, or it can be from the nerve supply to the muscle, or it can be the root supply to the muscle. Anything it can be. No. So let us analyze which is the nerves that supply gluteus, medius, and minimus. Superior gluteal nerve. Which is the root? Which is the root? L5. L5.
Yes.
So what we are getting is only the movement. We do not know whether it is at the level of the muscle, or it is at the level of the nerve, or it is at the level of the root. We don't know. So let us imagine that it is at the level of the muscle. No? So can you think of any condition which can affect gluteus medius and minimus muscle on one side? Can you enumerate some conditions?
It was only.
Tell me.
It is
asymmetrical.
Single muscle involvement.
So it can be, if it is only the muscle level, then you have to consider asymmetry is very, very unusual. You see, if it is at the level of the muscle, metabolic myopathies, hypocalcemia, or nutritional myopathy, or paraneoplastic myopathy, or inflammatory myopathy, whatever muscle disease, you will not think of genetic muscle diseases because his age is bar for that. So if it is any acquired muscle disease like inflammatory or metabolic or nutritional, toxic, then it should be symmetrical. So some disturbance, no? What is the problem? From where is it coming? Maybe somebody is not unmute. Somebody is not muting. Huh?
It's coming from the presenter itself.
Like that, huh?
Yes, ma'am.
So if it is muscle disease at this age, we will think of, am I audible?
Yes, ma'am, you're audible, ma'am.
We will think of muscle diseases at this age in a low middle class person, whether it is nutritional, osteomalacia, calcium deficiency, or is it inflammatory muscle disease, or it is metabolic due to some endocrine disorders. So these are the things we will consider in which state it should be symmetrical. So it is very unlikely, if the symptom of asymmetry is correct, it is very unlikely that it is coming from the muscle. Only thing which is purely motor and can come in an asymmetrical fashion, even in older person, whether it is an anterior hornsel disease. Anterior hornsel necessarily is asymmetrical, wasted leg syndromes, but still it is much younger. But this age also it can come. So anterior hornsel can come asymmetrically. Muscle will be, whatever is the cause at the level of the muscle, it will be bilateral symmetrical. So very unlikely to be at the level of the muscle. It can be anterior hornsel. It can be nerve. So inferior gluteal nerve. If the inferior gluteal neuritis, so there will be pain to start with. Even though it is predominantly a motor nerve, any nerve irritation will produce some pain, and it is very, very unusual for any infiltrating lesion to spare the inferior gluteal nerve and pick up the superior gluteal nerve and leave rest of the muscles which come from the lumbosacral plexus. Still we will keep it whether it is a superior gluteal neuritis. At that time, I am telling when the disease started. Third, whether it is a radical, very much possible. So radiculopathies are very, very asymmetrical to start with. So it is an asymmetrical hip abductor weakness involving the L5 root. So what are the other muscles? So radiculopathy is a high priority. And the next will be anterior hornsel disease. Superior gluteal neuritis is very, very uncommon. It usually is part of a lumbosacral plexitis. In the absence of anything else, it is a theoretical possibility. So first will be radiculopathy, second will be anterior hornsel, and third will be superior gluteal nerve neuritis, considering the asymmetry. So what are the other muscles supplied by the root? So if it is a mixed root, if it is an L5S1 mixed root, as I have previously told, you have to think of sensory, motor, and reflex. So three components are there for any root: sensory, motor, reflex. So sensory for the L5, where is that? Presenter would like to answer. Where is the L5 sensory loss? Nobody is hearing, huh?
Ma'am, you're audible. You're audible.
Presenter is unable to answer. What is the problem? Nobody is responding.
Yes,
any issue?
I'm trying to figure it out. Ma'am, I'm trying to figure it out, ma'am.
Okay. You see, yeah, if it is, as I have previously told, sensory, motor, reflex, you have to think. So if it is a radiculopathy, L5 root, I don't know whether anybody is benefiting, because no sound from that side. Nobody is answering. What is the issue? Anybody listening or not listening? Presenter is there or not?
Yes, ma'am, we are listening, ma'am. Ma'am, the participants are there, ma'am. Yes, ma'am.
Okay. So if it is L5 root, muscles which are supplied by the L5 root are gluteus medius minimus. Then you have got extensor hallucis longus, extensor digitorum longus, extensor digitorum brevis. They are the muscles. So you should examine, we should keep it in a radiculopathy is very much possible. So keeping that in the mind, when we go to examine the patient because of the asymmetry, we will look at the extensor hallucis longus, extensor digitorum longus, extensor digitorum brevis. Then the sensory is in the lateral part of the leg. If it is a mixed sensory motor radiculopathy, you will have a root pain which is along the distribution of the root, and you will have sensory loss in the lateral part of the leg, and you will have hip abductor plus EHL, extensor digitorum longus and brevis involvement. If it is a mixed radiculopathy. If it is a motor radiculopathy, the sensory component will not be there. Root pains will not be there. Or if it is a demyelinating radiculopathies. If it's a demyelinating radiculopathy, the proximal muscle will be more weak than the distal. That is because the myelin component in the short part of the root is more and the long part of the root is less. So the proximal muscles will be more weak. So this is the pattern if it is an L5 radiculopathy. Mixed radiculopathy will be sensory motor, and motor radiculopathy will be purely motor. And if it is a demyelinating radiculopathy, the proximal muscle will be more affected than the distal, which is supplied by the L5 root. So that is the first possibility I will consider if this patient comes like this. Second possibility, as I told, is an anterior console disease, which can be a symmetrical motor. And the third possibility will be superior gluteal nerve. Muscle disease is very unlikely. So what is the next symptom? Here, difficulty in pedaling. What was the difficulty while pedaling?
He has difficulty in putting. Yes, ma'am. Yes, difficulty in putting pressure while cycling, ma'am. While pedaling.
Downward pressure? Was it the downward pressure?
Downward pressure, ma'am.
So if it is the downward pressure, it can be either the plantar flexors of the foot, or it can be the quadriceps, which pushes down. Knee extension. So whether it is a quadriceps, we don't know. It is likely to be quadriceps. Or if it is a plantar flexor, patient will be able to tell that he has a slapping while walking. So pressing down is plantar flexors, which is the calf muscles, or it can be knee extensor. So either of them may be involved. And if we, let us imagine that it is the knee extensor. So if it is a knee extensor muscle, what are the possibilities? Again, because it is so much asymmetrical, if it is knee extensor at the level of the muscle, again it is so much asymmetrical, muscle disease is very, very unlikely, less likely. Theoretically, very less likely. If it turns out to be muscle disease, which you have put in the session, I will be surprised. Yes, this is not a way muscle diseases person. And the next will be, what is the nerve supply to that muscle? It is the femoral nerve. Third is the L3 root. So these are the three things you will consider. Is it the muscle, or is it the femoral nerve, or is it the L3 root? Femoral neuropathies are very unusual in other than diabetics. So diabetic patients can develop femoral neuropathy, or it can be due to pelvis injury. It is due to abduction injury to the pelvis. Then the femoral nerve gets damaged. Diabetes is one cause for femoral neuropathy or pelvis injury. Such a thing did not happen. So we will keep it aside. Here again, the radiculopathy is more common. If it is a L3 radiculopathy, the prime muscle supplied is only quadriceps, and the knee jerk will be depressed on that side. So that will be the, and L3 root supplies the lower 1/3 of the thigh. So if it is sensory motor, again, like I told, L5 radiculopathy. If it is a sensory motor L3 radiculopathy, lower 1/3 of the thigh will be affected, as well as quadriceps will be weak, and knee jerk will be depressed. If it is a femoral neuropathy, you have got the anterior cutaneous nerve of the thigh, which comes from the femoral nerve. That may or may not be involved. And the sensory, if that is involved, you will have a long strip of sensory impairment, not like the L3 root. L3 root is transverse. As you know, L1 root is just below the inguinal ligament, L2 root is mid-thigh, and L3 root is distal thigh. Whereas if it is a femoral nerve and is anterior cutaneous branch, it will be a longitudinal strip of sensory impairment, and then the knee jerk will be impaired. If it is due to plexopathy, other nerves which come from the lumbosacral plexus like adductors, obturator nerve. So it can be, so knee extensor weakness can be muscle, or it can be nerve supply to the muscle, or it can be root supply to the muscle, or it can be from the lumbosacral plexus. You diagnose each one by lumbosacral plexus, more than one nerve coming from the plexus. So it is femoral nerve plus obturator nerve. If they are involved, you will think it is plexus, plexopathies. Or if it is only nerve, sensory motor reflex, as I told, the pattern I have described, and L3 root also the pattern that is described. Here again, I will think that radical is the most likely possibility. And why is this radical proximally present? Even though L5 radical has got distal muscles also, why it is proximal predominant, all those things we can discuss later as we complete the anatomical localization of our patient's problem. So first is gluteus medius minimus. Next is probably knee extensor, plantar flexor plus minus. Plantar flexor, what are all the plantar flexors? Muscles, gastrocnemius, soleus, plantaris. These are the muscles. Whether they are involved or not, we will need more information. Probably it is the quadriceps. The next thing you told, he has difficulty in climbing up. So what was the problem while climbing up? Was he dipping his hip, or was he having a Trendelenburg effect? You see, while climbing up, as I have discussed in the previous session, you will have to, what we discussed in the previous session, you should incorporate in the subsequent session. So while climbing up, you may feel that you are not able to lift your leg and put it on the step above. That happens. So patient will say that I have difficulty. So I am lifting my thigh with my hand and putting it on the step above. That means it is hip flexor, iliopsoas. So climbing up can be difficult due to iliopsoas weakness, when the patient will mechanically lift his leg and put it on the step above, and alternate climbing will not be possible. So you'll put his leg on the step above, stand there, put the opposite leg on the step above, stand there like that. So quick alternate climbing not possible, and mechanically lift the thigh with the hand. Supposing it is a hip abductor which is already weak, then patient will have a Trendelenburg effect. So the hip will have waddling. So he will say that he is difficult in abducting, and so he will take the support of the reeling. But he generally do not lift it. Unlike the hip flexors, it is the Trendelenburg. So there is a waddling tendency. Next is the hip extensor. So if the hip extensor is weak, that is gluteus maximus. If that is affected, that pelvis will dip on that side. When the patient is climbing up, instead of the pelvis going up, it will dip. So all this, or if it is due to knee extensor, which is already weak, then when the patient is trying to climb, he will buckle. So you have to elicit all those symptoms so that we will know, is it the quadriceps, which is already weak, or is it the gluteus medius and minimus, which are already weak? They are the culprits, or some new muscle, iliopsoas, is getting involved. Unless you get the semiology properly, we will not be able to decide. So let us imagine that it is not that he is mechanically lifting his leg. So maybe it is a hip extensor, I don't know. Because if he is mechanically lifting, he would have told you. But you should elicit, as we have discussed these points in the previous session, you should automatically elicit these symptoms and present so that we are precise in our localization. So climbing up is difficult. What is the difficulty? We don't know. We have to elicit those things. If it was available, that is what I have discussed is the possibility. Maybe it is hip extensor, I don't know. So that was the climbing difficulty. Then you told he has difficulty in getting up from the chair. What was the difficulty? He has to hold on to the side of the arms or side of the arms of the chair and lift his hip, or he cannot even get up that way also. If it is the muscles involved are hip extensors and spine extensors. So hip extensor and spine extensor are involved in getting up from the chair. If the hip extensor is involved, because the spine extensor is there, patient can get up, but he will hold on to the hands of the chair and get up. If both hip extensor and spine extensor are weak, he will not be able to get up and somebody will have to pull him up. So what is the difficulty? You will have to again, because difficulty is the late term which the patient will tell. Difficulty can be pain, difficulty can be laziness, difficulty can be stiffness, rigidity, spasticity. So difficulty does not convey any meaning to us. So you should really tell what was the problem. Did he have to hold on to the side and slightly lift the pelvis, then he can get up. Or even he cannot lift up the pelvis at all and somebody has to pull him up. All this information, was he stiff or fly? Was he feeling rigid, tight, pain? All those symptoms you should tell, because difficulty is the patient's name. Okay, history should be in the patient's own words. But history of the presenting symptoms should be based on our knowledge. We will have to expand the history based on our knowledge, ask all the history, otherwise we will stand on the square in which our patient is standing. So the difficulty, I presume, so if it is a painless difficulty and it was not that he was holding, he was able to not get up at all, so probably it is a hip extensor, because you are also told that he has difficulty in climbing the stairs. So it is gluteus medius minimus followed by quadriceps followed by probably gluteus maximus. Next symptom, you told that he has difficulty in gripping the chappal. Which muscle is involved in gripping the chappal? Would you like to tell? Which muscle is involved in gripping the chappal?
Unmute yourself, ma'am.
It is the adductors. It's the intrashi. No. So it is the adductors. Gripping of the chappal comes from the adductors. So probably the adductors were involved. Did he have, and I have previously also told that gripping of the chappal becomes weak even in upper motor neuron disease. Sensory defect. All situations it becomes. So somebody saying gripping is difficult, then you have to ask, was he able to put his feet into the chappal? Was he able to hold on and walk? Was he able to remove the feet from the chappal? So putting the chappal.
He could put his feet onto the chappal. He had only difficulty in gripping. He could feel the sensation also. And while putting his foot out of the chappal also, he had difficulty.
So what do you think it is? While putting the chappal out of his seat, what is the difficulty? Was the fingers riding? No, what is the difficulty? Was the finger riding over? While he wants to remove the chappal from the feet, you said some difficulty is there. What is that difficulty?
He had difficulty in extending.
Extending what? We are not extending anything, no? When we remove the chappal. No. Removing the feet from the chappal is a passive process. No. We just remove the feet from the chappal mechanically only. It doesn't involve any extension. There is no extension at all. Only thing, when the difficulty in gripping is due to upper motor neuron, then it is not the muscle, it is the kinetic melody. When the kinetic melody is lost, putting in will be difficult, holding on and walking will be difficult, and when he wants to remove the feet, the fingers will override, because the agonist, antagonist, synergist and fixator are not properly coordinated. So what will happen? The one muscle will come over the other, so the little finger will come on the big toe, so patient will have to mechanically separate the toes. Otherwise, so if that is there, it is upper motor neuron. If it is at the level of the interossei, putting the chappal will be very easy because the space is more. Holding on walking is difficult because you cannot bring the toes together. Removing the feet is very easy because the space is already wide and he can simply remove it. And if it is sensory, if he fixes his vision on the feet, he can easily walk because the power is there. If he removes his gaze from the feet, the chappal will slip off. He will not know. Patient will say that he has moved 4 or 5 feet forward and he finds a chappal behind. That is sensory. So considering the way this patient's symptom is evolving, I feel he probably has a easy putting the chappal and difficult holding and easy removing. Most probably it is intrashi. That is the way it is evolved. So the muscles involved are gluteus medius and minimus, quadriceps, gluteus maximus. Then it is the interossei. You started on one leg and went on to the other leg. You said there is no fasciculation, there is no cramps, no root pains, no sensory features. Then he went on to the upper limb. Upper limb, you said it was lifting the hand above the head. Throughout the range or partially or initial or mid or throughout?
Initially, he was not able to reach above. Yes, ma'am. Above head, it was difficulty. Later, throughout, he noticed the difficulty, ma'am.
In that case, what if the throughout the all range is involved means it may be supraspinatus, which is the initial 30 degrees, and deltoid up to 90 degrees, and trapezius the last part. If throughout the range he has difficulty, probably all the 3 muscles are involved. Supraspinatus, which is applied by nerve to supraspinatus. That supplies, if it is the nerve to supraspinatus, it supplies both supraspinatus and infraspinatus. So if it is involved at the level of nerve to supraspinatus, when we will have to keep in mind, we will examine whether his infraspinatus is also involved. If both are involved, it will be nerve supply to that. If it is, what is the root supply of supraspinatus?
C5.
Very good. So what are all the other muscles supplied by C5?
Rhomboideus, serratus anterior, then teres major, and pectoralis major also.
Which one?
Pectoralis
C5 root.
major.
What is the sensory supply of C5? It is the outer part of the upper arm. C5 root supplies the outer part of the upper arm. The muscles that are supplied are supraspinatus, infraspinatus, deltoid, and biceps. The main muscles which are supplied by C5 root are supraspinatus, infraspinatus, deltoid, and biceps, which are the most symptomatic muscles. Teres major, minor are very small. What muscles are, what is the root value of pectoralis major?
C5 to C7.
It is C7. You see, you should tell me about the most. Pectoralis major is C7. So it is not C5. So C5 is a very prime root for the upper limb. Very commonly involved. The muscles affected are supraspinatus, infraspinatus, subscapularis, deltoid, and biceps. So these are the muscles, and the biceps jerk will be affected. Sensory impairment will be on the outer aspect. Instead, if it is the whole range, any problem? No? So, or whether it is the whole muscles, all the muscles are involved, on both sides are involved, it can be muscle, we do not know, it is not respecting a root, because it, see, deltoid is involved, but you said the terminal trapezius is also involved, which is a higher root.
Yes.
Whether trapezius is involved, when we examine only we will know, because we will have to look for trapezius power, or is the first up to 90-degree impairment itself will impair all the activities which he is doing, in which case it can be C5 root, but it is predominantly motor. Everywhere it is motor only, we didn't get any sensory component. But still the pattern is radicular. The pattern is radicular is the first. Asymmetry is a very significant thing, and 4 months asymmetry, it is a radicular pattern. So upper, that is upper limb. Next, you told that he has difficulty in opening the bottle. So opening the bottle is done by which muscles?
The forearm muscles, ma'am. The brachioradialis.
Brachioradialis, what is the action of brachioradialis?
Flexion in the semi-prone position.
So do you open your bottle with flexion in the semi-prone position? No, it's a distal muscle. No, you are not using brachioradialis is semi-prone flexion, correct. It is C6 root. So opening the bottle is not by semi-prone flexion. It is by lumbricals. Opening the bottle is by lumbricals come together. Then they turn like this. Then the interosseous and the opponents will come. So opening the bottle is by lumbricals supported by opponents and the interosseous. This is small muscles which are supplied by the C8D1 root. So sensor is not there. So we will see where it's a predominantly motor. So is it a muscle or a root, all those things. So would you like to tell for the benefit of everyone how we will differentiate C8D1 root from the posterior cord, medial cord C8D1 root, ulnar nerve, as well as the muscles, small muscles. You see, that is the differential diagnosis. Small muscles, primary disease of the small muscles of the hand, or it is for a theory I am asking, or is it the ulnar nerve, or is it the C8D1 root, or is it the medial cord, or like this. Would you like to tell me how to differentiate? What is the commonest cause for small muscle wasting in a man of 68 years? Commonly, it is a cervical spondylosis. People with cervical spondylosis will have false localizing sign. When we discuss spinal cord before, I have told, they will tell with pain in the neck and radiating and all those things. When you examine, you will find small muscle wasting. That is called a false localizing sign. The compression may be higher. It is due to venous stasis. So commonest, most of the people in this age group will have small muscle wasting, which will not be in their complaint at all. When we examine, we find that their small muscles are wasted, and that is due to cervical spondylosis. That will be purely motor only, because it is not due to the root. It is due to venous stasis ischemia in the anterior horn cells of the C8D1 region. Second cause is motor neuron disease again, purely motor, small muscle wasting, which is symptomatic. It may be at the level of the anterior horn cell, again purely motor. Next, I told how are you going to think of ulnar nerve. Ulnar nerve has got a sensory motor reflex. Ulnar nerve supplies all the small muscles of the hand except the thenars. So even in the thenar, the adductors are supplied by the ulnar nerve. So when you examine, all the small muscles are affected except the thenar muscles which are supplied by the median nerve, and even in the thenar the adductor is affected. That is the motor. Second, if it is a proximal ulnar nerve, medial forearm muscles may be affected. And third, you will have a sensory loss in the lower 1/3 of the medial part of the forearm. So if it is ulnar nerve, all the muscles other than thenars, lower 1/3 of the forearm sensory impairment, as well as you will have, so that is the ulnar nerve, lower 1/3 sensory impairment. Medial forearm muscles involved or not depends on the level in which the ulnar nerve is involved, and all the small muscles other than the thenars, that is ulnar nerve. Next we will go to the medial cord. Medial cord supplies the medial root of median nerve also, because the medial root of median nerve supplies the thenars also. So if it is medial, all the muscles supplied by the ulnar nerve pattern of sensory loss plus thenars means you have to think of medial cord. So medial cord supplies the medial root of median nerve, which supplies the thenars. But pectoralis will be involved, which is medial pectoral nerve is coming. So if all the muscles are involved, including the thenars, and there is an ulnar nerve pattern of sensory loss, and pectoralis is involved, then you will think it is a medial cord. That is the medial cord. Then you have got the C8D1 root. In this age group, you should never forget C8D1 root, because they can have carcinoma of the lung, pancreas tumors. that infiltrate into the C8D1 root. So it will have severe radicular pain. Usually they have got horners. They will have horners and all the small muscles. We have C8D1 root, both C8 and D1 is affected, means all the small muscles of the hand will be affected. Forearm muscles will not be involved. And the C8D1 sensory is along the medial aspect of the upper arm and the forearm. Whole of the medial aspect of the upper arm and the forearm. So C8 is here, D1 is here. So C8D1 root will be whole, unlike ulnar nerve, which is distal 1/3. Whole of the medial aspect of the upper arm and the forearm sensory impairment, Horner syndrome, plus all the muscles. We have C8 and D1 is there, all the muscles. So it will look like medial cord in the sense that all the small muscles are involved. It will be differentiated from the medial cord because the medial cord does not have a sensory supply to the upper part of the medial part of the upper arm, which is there in C8D1 root. And medial cord does not produce horners, whereas C8D1 root will produce horners. And C8D1 root will never involve pectorals, whereas medial cord will involve pectorals. So that is how all these are differentiated. We will keep it in our mind. He had a small muscle wasting. Probably all the muscles were involved, I am thinking. So that I will keep it in my mind. And I am not able to put it into other distribution because it is purely motor in this context. Next symptom you told, then he developed difficulty in mixing food. Which is the muscle involved in mixing food? Lumbricals. So opening the bottle involves all the muscles, lumbricals, intraossei and opponent. Whereas mixing food is lumbricals. So it is already involved by opening the bottle difficulty. So that is there. So you have got proximal to start with and then distal in the upper limb. And then you have got difficulty in turning in the bed. So turning in the bed is by which muscles?
The
trunk muscles. So if it is, it involves erector spinae, it involves the oblique muscle and the oblique muscles of the abdomen. Supposing patient says that he has difficulty in just lying down and turning, but if he tilts his trunk a little, he can get it, that means the obliques are all right. And it is only the erector spinae. But if all the movements, he is not able to make any movement with the trunk, it is the whole of the paraspinal muscles, including the obliques, are probably involved. At what level, again, depends on many other components. So we will keep it like that. Next, you told that he has difficulty in holding the head up. Which muscle is involved in the holding the head up? That is a neck extensor. No. So who is the neck extensor? The neck is remaining flexed, you told. He is unable to hold his neck in extension. So was his neck flexion possible? Flexion is easier. Is his neck flexion easy? Maybe, because the neck is
he has both difficult flexion of the neck also.
Extension, both are difficult. Okay. So which are the neck extensors? Which are the neck flexors? Would you like to enumerate? Neck extensors. Sternomastoid is the main neck flexor. Very good. Then it is supported by what other muscles? Ribbon muscles and the scalenes. So neck flexor.
Ribbon
yes.
muscle.
Would you like to name the ribbon muscles? Sternohyoid, sternothyroid, thyrohyoid, omohyoid. So it is sternocleidomastoid plus sternothyroid, sternohyoid, thyrohyoid and omohyoid plus help from the scalene muscles. That is neck flexion. What are the neck extensors?
Neck extension mainly by the upper fibers of the trapezius and the rhomboideus.
Neck extension is by the upper fibers of the erector spinae. That is a main neck extensor, which is supported by the other neck muscles. Which are they? Synergistic muscles, longissimus capitis, longissimus coli, splenius capitis. So longissimus capitis, longissimus coli, splenius capitis, upper fibers of the erector spinae. And of course, as you said, trapezius is not a prime extensor of the neck. It is just a synergistic muscle. The trapezius action is shoulder shrugging. It is for shoulder shrugging and fixing the upper part of the scapula to the ribs. That is the function of trapezius. It has got some synergistic effect, but it is not the prime neck extensor at all. It is abduction of the shoulder beyond 90 degrees, shrugging of the shoulder and fixing the upper scapula to the rib. That is the action of the trapezius. So all these muscles are involved. So now if you want to enumerate the muscles involved, it is gluteus medius, gluteus minimus, quadriceps, gluteus maximus, then the small muscles of the foot, then it is the supraspinatus, deltoid plus minus trapezius and all the neck muscles. So it's a rapidly progressive purely motor syndrome. So at this, in this age group, rapidly progressive purely LMN. What are all the differential diagnoses you have to consider? It is 4 years duration, not rapidly progressive. Rapidly means 1 year, within 1 year it should progress. So it is a progressive LMN syndrome involving all these muscles. What are all the differential diagnoses? Then we will go to the diagnosis point, examination. I will and what are the odd points? I always told that when you examine a case, you have to take the hard signs, the soft signs, and the odd signs. So the hard signs in this patient, very severely disabling, predominantly motor, LMN syndrome, which started proximally, and both upper lower limbs to start with, and then went on to the upper limbs, then involve the neck muscles and the trunk muscles. So that's an undisputable hard sign. And what are all the soft signs in this patient? He is not having really much soft signs, like misleading pains and other things are not there. What is the odd sign? Asymmetry. So asymmetry is the odd sign. So that will be the most important sign that you pick up in this case to make a diagnosis. So if it was symmetrical and spread up like this, I would have think of primary muscle diseases which manifest in the old age, like inflammatory muscle disease, metabolic muscle disease, and or it's a nutritional muscle disease. All those things I would have considered because it is a purely motor if it was symmetrical. If it is asymmetrical, anterior hornsel disease is still a possibility. As you know, at the bedside, anterior hornsel is classified into purely LMN, purely UMN, LMN plus UMN. And they are typically asymmetrical. And they present in the older age. So anterior hornsel is a strong possibility. But you said that there is no fasciculations, so no tremors, and it has no bulbar muscle involvement, no tongue muscle, or no cranial muscle involvement. Still, it remains a possibility. Third is the radiculopathy. Radiculopathies are motor radiculopathies like CIDPs, chronic inflammatory radiculoneuropathies. They will start proximally, asymmetrically, and go distally. So that will be my order. So my first diagnosis will be a variant form of chronic inflammatory radiculoneuropathies, which are typically proximal. Even though it is a radiculopathy, these radiculopathy do not respect the root territory. They respect the myelin because they are demyelinating. Because they are demyelinating, they respect the myelin. And the maximum myelin is in the shortest course. The shortest entry is to the proximal muscles. And classically, CIDPs present with the proximal involvement and later progressing to distal. They can be asymmetrical. So my first possibility will be chronic inflammatory radiculoneuropathies, taking the classical clue of 4 months asymmetry in the lower limb. It started in a length dependent fashion, but it was proximal to start with, probably respecting the myelin. Sensory is very less. When you examine only, you will find sensory in these patients. So my first diagnosis for him is CIDP, which can be asymmetrical. Next, whether it is anterior hornsel, I will not consider muscle disease. The next clue in this case is the neck muscle involvement. So neck muscle involvement among all these conditions, if you want to eliminate what are all the conditions where neck muscles get involved. One is anterior hornsel disease again, dropped head sign. A large series was published and presented by Gauri Devi madam from NIMHANS. So dropped head syndrome is very typical in anterior hornsel disease. One. Second, you can get it in polymyositis. But polymyositis, neck muscles are involved, esophageal muscles are involved. So they will have swallowing difficulty, and they do not involve the distal muscles. Till very, very late, till end stage, they do not involve the distal muscles. So in this patient, polymyositis is very unlikely. M&D is possible. Neck muscle involvement happens in M&D. So it can be M&D, which I am considering as, and it can happen in radiculopathy when it involves the whole roots, or CIDP, still the possibility. But polymyositis, paraneoplastic, older age group, paraneoplastic polymyositis, a high possibility, but he never had pain. So how to differentiate him? Acquired muscle disease is presence of pain, because pain means the non-muscular structures of the muscle like epimysium, perimysium, endomysium, intramuscular nerves, vessels. When they are involved, only pain comes. Polymyositis or inflammatory muscle disease, they just are not disease of the cytoskeleton of the muscle. They involve the supporting structures of the muscles as well. So pain is a feature, and my patient never had pain. So I am not going, and he does not have swallowing difficulty, because the upper 1/3 of the esophagus, which contains skeletal muscle fibers, typically get involved in polymyositis. So even though neck muscle is seen in polymyositis, I will not consider polymyositis, because there is absolutely no pain and he has no swallowing difficulty. Even though paraneoplastic polymyositis can manifest in this age group, I will not consider it as a possibility. Third will be myasthenia. Myasthenia patients can have bulbar weakness, ocular weakness, neck muscle weakness. But myasthenia does not present. Limb girdle type of myasthenia is there, but that myasthenia does not involve the distal muscles. Considering the neck muscles, I am discussing this. So myasthenia is not at all possible. Radiculopathy is possible. M&D is possible. Polymyositis is not possible. Myasthenia not possible. Other condition where neck muscle gets involved is myotonia. You might have seen myotonic dystrophy patients. They will be bald, they have cataract and very thin, long, that we call it as cadaveric faces, because their neck is thin, their face is thin, and they look like cadavers. So that also involves the neck muscles, which is not at all there, and it manifests much younger. It is a dominantly inherited disease. So again, taking the neck muscle as a possibility, again the differential diagnosis becomes only radiculopathy and anterior console disease. So my first possibility in this patient is CIDP, radiculoneuropathy, and second possibility will anterior console. How to differentiate? One, you can have fasciculation fibrillation that is favoring, but it is not an absolute point. Tongue involvement is favoring anterior console. Bulbar involvement is anterior console. Those points are not there in this patient, but CIDP will look like motor. Only thing you have to, because it's a myelin disease, as I told. The most myelinated fibers are the motor fibers and the proprioceptive fibers. So it may be the timed vibration, mild involvement of vibration, proprioceptive fibers, which the patient may not be able to tell. And when you examine, you find that vibration is impaired. That will be the clue. So when you examine, you have to specifically look for timed vibration. So that will help us. You had put it as myositis. You see, for acquired muscle disease, some warning signs are there. One is the presence of pain. As I told, pain never occurs in primary muscle disease, which involves a cytoskeleton of the muscle. Like the brain, muscle fiber is also not pain sensitive. Brain is not pain sensitive, muscle fiber is not pain sensitive. But the supporting tissue of the muscle, like perimysium, epimysium, endomysium, intramuscular vessels, and intramuscular nerves are pain sensitive. So if there is a pain, all these structures are involved in addition to muscle. So that will point to an inflammatory muscle disease. That pain is not there. Second, if there is a fatigability, you should never forget. It may be still limb girdle myasthenia. So after walking some distance, I am buckling. After resting, always ask, because limb girdle myasthenia will be often missed. So they are warning signs. So there is no fatigability. Third, exaggerated reflexes. They are usually, most of the muscle diseases, nerve diseases, reflexes are depressed, whereas exaggerated muscle reflexes is a point in favor of metabolic, endocrine, inflammatory muscle disease. Fourth, systemic involvement. So in this patient, it is a proximal more than distal, asymmetrical, significant proximal and distal, and extensive involvement of the trunk and the neck muscles, slowly progress, apparently motor. When we examine, I think we will find proprioceptive impairment, and my first diagnosis is CIDP. Chronic inflammatory radiculoneuropathy is my first diagnosis in this case. So we will go to examine.
On general physical examination, patient is conscious, cooperative, oriented, no palar, icterus, clubbing, cyanosis, no lymphadenopathy, pedal edema. Length of the patient is 158 centimeters and weight is 65 kg. His BMI is 20 and BP is 120
BMI
by
is
70
how
mm.
How much is the
26.
BMI? Okay, very
26.
less. Okay.
BP is 120 by 70 mm of mercury. In the right upper arm, sitting position. Heart rate is 77 beats per minute regular. There is no ptosis, no facial asymmetry. There is no thinning or atrophy of the facial muscles on inspection, and no rashes over the skin. There is a bilateral drooping of the shoulders is present, and thinning of bilateral deltoid and biceps. There is thinning of the muscles of the back and the shoulder girdle. There is thinning of the forearm muscles. There are no contractures are seen. Thinning of the thigh muscles are present, and no spinal deformities.
What about clawing? Because the introsea were involved, no? Introsea were involved in the lower limbs, no? So does he have clawing of the toes? We expect that. When the toe grip is weak, usually the flexors will make the toes claw. You said, no, chappals were slipping off. So he may be having clawing of the toes. We can see that. Okay. Okay, go on.
Excuse me.
On central nervous system examination, higher mental functions, appearance is normal, behavior is normal, conscious, oriented to time, place, person, memory is intact, intelligence is normal, speech and language is normal, insight and judgment is normal, and the calculation was normal. There was no delusion or hallucinations. Cranial examination was normal, ma'am, except for there was weakness of the sternocleidomastoid and trapezius bilaterally.
Weakness of sternocleidomastoid and trapezius symmetrically. Okay.
Motor system examination. 1 second, ma'am. My slide.
Sternocleidomastoid, how did you check? What all the methods by which you checked? Both sternocleidomastoid. Tell.
You ask the patient to put turn towards one side and put resistance over the.
So you are checking the sternal head or the clavicular head? That time.
For that
you are checking the clavicular head. You know that sternocleidomastoid has a sternal head and a clavicular head. When the patient is turning the head to the one side, it is mainly the clavicular head. When you are flexing, it is a sternal head. Of course, when you are flexing, the ribbon muscles also come to assist. So you can just put pressure on the chin and tell him to flex. It will be the sternal head, and turn like this. That's the clavicular head. So that is weak. You said trapezius is weak on both sides. What are all the evidences for trapezius weakness?
You ask the patient to shrug the shoulders and you put resistance.
He's unable to.
That is unable to shrug his shoulders.
What else? What are all the features of trapezius weakness normally, and what all were present in this patient? He was unable to shrug the shoulder. What other features trapezius? You see, trapezius is a muscle which is coming from the suboccipital region, and it is coming through the shoulders. So it is responsible for the curvature of the shoulder. So if the trapezius is weak, we call it a squaring of the shoulder. Normally here we can draw a circle. When we have the curvature in the neck, a normal trapezius, we can draw a circle here. So when the trapezius is weak, it becomes lost. Contour is lost. So it becomes square. So you call it as squaring of the shoulder. So inspection, you will find trapezius produces squaring of the shoulder. And you said the shoulder is droop. Shoulder droops. So trapezius will produce drooping of the shoulder, squaring of the shoulder, And third, in the shoulder, you will get a scapular hump. You heard of scapular hump? Because the trapezius muscle anchors the medial scapula to the ribs. So the medial part of the upper scapula to the rib. So when the medial part of the upper scapula is not opposed properly to the ribs, it will come out and it produces a bulge here. So you stand in front of the patient and see, you will get a bulge here. So drooped shoulder, squared shoulder with a scapular hump. And he may not be able to lift his hand beyond 90 degrees and unable to shrug the shoulder, and you will have a winging of the scapula with rotation. It's an upper scapular winging. So upper part of the scapula will be winged and it will be rotated. Unlike serratus anterior, where the upper and the lower scapula is winged and the scapula will not be rotated. So scapular winging with rotation is trapezius, whereas scapular winging without rotation. Next, the winging of the scapula is brought out by abducting the shoulder. Whereas in serratus anterior, the winging of the scapula is brought out by pushing the hand forward. You push the hand on the wall and the scapular winging becomes prominent. It is serratus anterior. Whereas winging becomes prominent while abducting the shoulder, that is trapezius. And the serratus anterior winging is parallel to the spine. Superior angle and the inferior angle of the scapula is displaced parallel to the spine. Whereas in trapezius, upper part is more winged and it is away from the spine, and the lower part is less winged or not winged, and it is more closer to the midline. So these are the points. So before you say that my patient trapezius is weak, you should describe all these points. Among them, how many points you got? You got drooping. Squaring
Drooping
is
is
there.
ma'am. Squaring is also
weak.
there, ma'am.
Shrugging is weak.
Yes, ma'am.
Does he have scapular winging?
No scapular winging, ma'am.
Okay. So mild weakness probably. Mild weakness of the trapezius as evidenced by drooping and shrugging. Okay. What else? But you should know all these points because people will ask you, what are all the other features? Did you look for them? Were they present or not? No, then you should be able to tell. Next. Next, you tell
Coming
me.
to motor system examination. Nutrition, muscle bulk, right arm and left arm. Right arm was 22.5, left arm 23 centimeter. Right forearm 22.2, left forearm 20.2 centimeter. Right thigh 42 centimeter, left thigh is 44 centimeter. Right leg 36 centimeter, left leg is 34 centimeter. And the tone was normal in bilateral upper limb and lower limb. And power
normal or decreased? Tone is normal or
mild? It was almost normal, ma'am.
Okay. Did you do passive shaking? You can shake. They can keep the hands like this. Normally, when you do some tone examination, it is a subjective. So how do you define tone? Would you like to define tone? Because in your exams, people will ask you to define tone. How do you define tone? It is defined as resistance offered to passive movement. That is the recent definition. But the old definition is state of, that is still important. It is a state of partial contraction always present in the normal muscle for maintenance of posture with minimal expenditure of energy. So you have to maintain posture means you should have tone. So you check not only by passive movement, you should check the tone by asking the patient to maintain certain postures. You see, you can tell the patient to keep the hands like this. Normally you are seeing a right angle. If it is spastic, it will be, most of these hemiplegia patients, they cannot bring it like this, it will be like that. So it is spasticity, it will be a obtuse angle. If it is flaccidity, it will not be a right angle. So normal is a right angle, whereas hypo is an acute angle, hyper is an obtuse angle. So when you examine, if you are not able to appreciate properly, because it's a state of partial contraction, always present in the normal muscle for maintenance of posture. So you can check in these postures. Then you can do passively shaking. When you passively shake, When the patient is fully relaxed, it keeps on going more than 3 oscillations. So that you can check if all are normal, because so much of power loss is there, element syndrome is there, and we are expecting some degree of hypotonia. So you should do all the things, and then if it is normal, okay, you can say the tone is normal. That does happen. Then power is very, very bad. Shoulder flexion, extension, that is anterior, posterior, and middle fibers of deltoid. Abduction. So, and external, who is the external rotator of the shoulder? Who is the external rotator? You said external rotation is very less. 1. Who is the external rotator of the shoulder? Which muscle? Which muscle is the external rotator? Infraspinatus. Who is the internal rotator? Subscapularis. So very important, you should know. So the other muscles were there in the history only. So infraspinatus and subscapularis is also involved after examination. Elbow flexion. Elbow flexion is by which muscle? Elbow flexion?
Brachioradialis. Biceps.
Oh, biceps. No. Biceps is the elbow flexion. Elbow extension? Primarily triceps. So then wrist flexion. What are all the wrist flexors? Wrist flexors are slightly better. Wrist flexors are slightly better than the elbow flexors and elbow extensors. Who are the wrist flexors? Flexor carpi ulnaris, flexor carpi radialis, palmaris. Then, so they are the main wrist flexors are flexor carpi radialis, flexor carpi ulnaris, palmaris longus, as well as the flexor carpi ulnaris. You have got longus and brevis. So they are the wrist flexors. Which are the wrist extensors? Extensor carpi radialis, extensor carpi ulnaris, extensor digitorum. They are mainly the extensors. Extensors are better than the flexors. Ulnar deviation is by which all muscles? Flexor carpi ulnaris and extensor carpi ulnaris. Together they do the ulnar deviation. Radial deviation is also the flexor and the extensor. Together they are better. So the worst affected muscles are the proximal lower limb muscles, all the muscles, as well as the proximal upper limb muscles, and moderate involvement is seen in the wrist flexors, and better are the wrist extensors. Okay, next go to the lower limb.
Finger
Lower
flexors also.
Okay.
Hip flexors 1/5. The knee joint better. Knee flexors and extension was 4/5, and ankle dorsiflexors and plantar flexors were maintained.
So in the lower limb, proximal more than distal, and that is the muscles on the hip are worst affected than the muscles on the knee and the ankle. Okay, next.
There was no fasciculation seen. The neck flexors and neck extensors were weak. And coming to reflexes, biceps, triceps, and supinators reflexes were absent. Knee jerk and ankle jerk were preserved.
Okay.
Superficial reflexes were present. Then coordination we couldn't test because patient hand could, the movement was not there. Power was 1/5. And the gait, patient required support to get up. He could walk for some distance. There was no ataxia or swaying, ma'am. There was buckling at the knee while walking. Sensory system examination was normal, ma'am.
What all things you looked in the sensory system? What is the timed vibration? Vibration, did you check?
Yes,
Vibration, position, and dynamic joint sense. How much degree joint sense you could appreciate? How many degree of? I'm sure it will be embedded in this patient. Dynamic joint sense, how do we check? Fine methods of checking. So, fine posterior column, large fiber involvement of sensory. You should dynamic joint sense. You see, joint sense as such you check by lifting up, lifting down, and 8 out of 10 is correct means you take it as normal. But that is over more than 5 degree movement. So dynamic joint sense is a fine movement. You do 1 degree joint movement and see whether the joint movement is present or not. So that if it is present, it is normal. It's a fine test. Then you have to check the timed vibration. Timed vibration. What is timed vibration? You do the tuning fork, keep it on the angle, and find out for how much he is able to perceive vibration. Normally, the vibration is perceived for about 15 seconds in the angle and 20 seconds in the anterior superior iliac spine and 20 to 22 seconds in the upper limb. So if it is reduced, it is abnormal. And if the person is diabetic, he will lose 1 second per decade. Or if there is no neuropathy. So this person, he should perceive vibration for at least 13 seconds in the angle and 18 seconds in the anterior superior iliac spine. That is, so fine posterior column testing is done by looking for evidence of pseudoathetosis, looking for timed vibration, dynamic joint sense, and there is something called Dance D tendon, but you cannot examine in this patient. Dance D tendon means patient has to stand. When he is standing, if he is doing some movement with the distal part of the toes, that means he is trying to ascertain his proprioception. So fine posterior column is dynamic joint sense, timed vibration, and Dance D tendon. So now you have got a pattern in this patient where the proximal upper limb is worst affected and forearm level is moderately affected and distal is better. In the lower limb also, it is the hip muscles which are worst affected and knee muscles are better and the muscles in the ankle are again better. And vibration you have to very carefully check in this patient. So this what I have only one diagnosis. I'm sure it is CAD. Did you do the nerve conduction studies? Timed vibration, posterior column, fine proprioception, you have not checked. So did you do the nerve conduction? Why did you think of inclusion body myositis? What made you think?
Study was done. It showed axonal neuropathy involving the left radial, musculocutaneous, and axillary nerves.
Okay, that is not a feature of inclusion body myositis. So it's an axonal neuropathy. Why did you think that it is inclusion body myositis? What is the pattern of muscles involvement? First of all, it is very, very rare. And it never cripples the patient like this. Inclusion body myositis will not cripple the patient like this. So what is the muscle involved? It is the quadriceps in the lower limb in the young people, or if it comes in the older people, it is the forearm flexors and recti muscles. So it will be inclusion body myositis involves the distal forearm flexors, the forearm flexors in the upper limb, quadriceps in the lower limb, and extraocular muscles. And that is inclusion body myositis. It is definitely not inclusion body myositis. You should not diagnose inclusion body myositis. You see, it may be eminently treatable CIDP. Even though inclusion body myositis is can be paraneoplastic or non-paraneoplastic, it is very, very resistant to treatment, and you should not diagnose. It is not. And nerve conduction will not show amplitude reduction and all those things in these nerves. So nerve conduction should be normal, and it should show. I will not diagnose inclusion body myositis. You see, you did muscle MRI. Yeah? It is not. It is definitely not.
Muscle MRI.
You can write to
Muscle
the
MRI.
nephrologist. Yes.
Muscle MRI showed.
Yes. Muscle MRI showed what?
Diffuse fatty atrophy of the bilateral gluteal muscles and all compartment of both the thighs and posterior anterior compartment of the legs with active inflammatory changes with hyperintensity in T2.
Okay.
And
So
the muscle biopsy
was analyzed where? Muscle biopsy was analyzed where?
NIMHANS only.
You can request them to review the slide. you request them to review the slide, because it happens. It depends on whatever diagnosis you tell. You see, now all the non-specific changes will be put into the pathology. I'm sure you can tell that this picture is not at all like inclusion body myositis. Madam, many times you have done it. Because it is all one team. If you tell them some muscle disease, we will, you are telling them that there is an inflammatory muscle disease suspected, some non-specific inflammation will be there here and there. So fascicular architecture is partly replaced by fibroadipose tissue infiltration. Okay, that is non-specific. Fibers show moderate variation of the fiber size. Okay, scattered hypertrophic round fibers that can be seen in muscle disease. Internalized nucleus, atrophic angulated fibers in necrotic macrophage, regenerating fibers are seen. Prominent endomysial lymphocyte plasma cell and some myofibers have vacuoles. Who has reported that? Who has reported this? Dr. Nandisha. You request them, please. I am sure it is CIDP. This is not inclusion body myositis. This is definitely not inclusion body myositis. You write to them, because patient will improve very well. Prognosis will be good, even though the duration is 4 years. Whereas inclusion body myositis, this is not at all the pattern. You should not think of inclusion body myositis. This is only, you do plasmapheresis or give him methylprednisolone and see, he will improve. This is CIDP only.
Okay.
This is not inclusion body myositis. You write to the pathologist, madam, this is the clinical picture. Proximal more than distal, not at all. The elbow flexors, the wrist flexors are much better than the shoulder. Not at all a feature of inclusion body myositis. Wrist flexors are better than the shoulder. You only showed. And quadriceps is better, very good. Quadriceps is grade 4. And hip flexors are very weak. So this is CIDP, radiculoneuropathy. Typical radiculoneuropathy, CIDP. Rare things are rare, and you tell them something, pathologists will confirm. Because on these disorders, it is all vague. It is like cat on the wall. What you tell them, they will think whether it is correlating. They have not seen the patient, no. So you have to do a nerve biopsy. Did you do the sural nerve biopsy?
No, biopsy is not done.
Why? Clinically only you thought it is inclusion body myositis, huh? How it is possible to think at all? You see, you will not even think polymyositis. If you think polymyositis, I can think, okay, old man, you thought. But even that is very, very unlikely. So much distal involvement, no pain at all. And CK is normal. So much of distal involvement, normal CK, no pain at all, swallowing all right. You will never think polymyositis. You should, now is the patient with you?
Yes,
do
ma'am.
a sural nerve biopsy and tell them CIDP.
Okay.
Then you will see. This is not inclusion body myositis. NIMHANS pathology or clinician or what it is okay. It does not matter. You see, whatever information is given, remote changes will be there that will be considered possible with a diagnosis. That's all. This is not inclusion body myositis. So because pathologists told inclusion body myositis, totally different case. Clinically, you should not. You are clinician. Clinician is far superior to the laboratory person, and it is a teamwork. You give them a wrong diagnosis, they will give you a wrong diagnosis. So that is what will happen. Even demyelinating diseases pathologists in VIPs in Kerala, ministerial staff, politicians have been reported as gemistocytic astrocytoma when they had an ADAM, acute disseminated, because these are all variable. You tell I have done muscle biopsy. Who will do muscle biopsy for this case? You should have done a nerve biopsy. So much distal involvement, no? So you should make a discussion before you decide which part you are going to biopsy. Then give the correct picture to the pathologist. Then only they can give you. They have never seen the patient. They have not examined the patient. As I told you, one VIP politician here was radiated with a diagnosis of gemistocytic astrocytoma given from CMC Vellore. You see, premier institutions in the country. Nobody took history. Nobody bothered to understand what it is. Some kind of big lesions were there. It was in 3-4 days because politicians running for life. He went to Delhi for some meeting. There he got it. He came to Trivandrum Sri Chitra. There tried to do a stereotactic biopsy which failed. Immediately got into the next flight, Gendu. Nobody then bothered to ask history. Which astrocytoma will come in 1 week time. So everybody chased the shadows. Finally, he was radiated without slide review. Myositis are reactive glial cell, like these inflammatory cells. They'll be there everywhere. Are they pathogenic or not? So because everybody said masses are there, Myositic astrocytoma, politician, he was given a priority, radiated and killed. He died. You see, it was acute disseminated encephalomyelitis, Adam. Nobody bothered to take the history. So you should never make your diagnosis based on laboratory. Instead, you should give correct opinion to the laboratory person and request them whether it is correlating. Any tissue will have some non-specific change, especially 68-year-old person. And because you are giving them a diagnosis, they are giving you. This is not at all a case for muscle biopsy. You should have done a nerve biopsy. So this is CAD. You know the pattern. No, there is something called pattern recognition. In muscle disease, we tell limb girdle pattern. If you have a limb girdle pattern, in younger age group, they are all the dystrophic muscle disease, proximal girdle pattern. They are the dystrophic muscle diseases in children. Or little more older, it may be LGMD, autosomal dominant, autosomal recessive. That is the proximal girdle pattern. Second, in the proximal girdle pattern, you have got metabolic muscle disease, endocrine muscle disease, toxic nutritional muscle disease. They are all proximal symmetrical girdle pattern. Then you have got a distal pattern. They are seen in young people. Nerve conduction is normal. Very young people, they are distal myopathies. Distal myopathies, you have got anterior group in the lower limb is Nonega, posterior group in the lower limb is Myoshi, and in the upper limb you have got the Willanders laying. These are the distal myopathies. Depending on the gene loci, they are laying or Greek or Willander. Depending on the group, it is Nonega or Myoshi in the leg. They are symmetrical distal myopathies. So, proximal girdle pattern is the dystrophies, LGMDs, nutritional, metabolic, endocrine, toxic, nutritional. Next, distal, only young people, all these myopathies, Willanders and all those things. Then if you have proximal in the upper limb and distal in the lower limb, that is facioscapulohumeral dystrophies, scapuloperoneal dystrophies. So proximal upper limb and distal lower limb, facioscapulohumeral and scapuloperoneal dystrophies. Then you got distal upper limb and proximal lower limb, that is inclusion body myositis. Distal upper limb, forearm flexors and quadriceps. So distal upper limb and proximal lower limb is inclusion body myositis. Then you will have to cranial muscles. Among them, you have got the facial muscles and the neck muscle. So neck muscle involved angiocondylar disease, myotonic dystrophy, polymyositis, M&D, and that is neck muscle, myasthenia. Then cranial muscles, facial muscle is facioscapulohumeral, ocular muscle is myasthenia, thyroid myopathies, then parasitic myositis, then myotonic dystrophy, mitochondrial disorders. Bulbar muscles, myasthenia, oculopharyngeal myopathy, M&D. So this is the pattern. You have got a proximal girdle pattern, distal girdle pattern, proximal upper limb and distal lower limb, and distal upper limb and proximal lower limb, and cranial muscles and limb muscles, and you have got neck muscles and limb muscles. So this is complete, including the trunk, neck, everything is involved. This never happens in inclusion body myositis. NIMHANS pathologists are very, very helpful. They are extremely understanding because they know that nobody is the last word. You just write to them, take a sural nerve biopsy and send, you will get the correct dip. You misguide them, they accordingly report. These are non-specific. They are very, very good people. They are one of the best in the country, and they know that they make a diagnosis correlating with the clinical picture is very important, and you give a wrong tissue, you get a wrong diagnosis. This is not inclusion body myositis at all. And unfortunately, you see, do not chase the MRIs, do not chase the pathology. Do not chase the laboratory. They all can be wrong. But you are the clinician. You have your eyes, you have your hands, you have your brain. Why do you want to depend on the lab and call me inclusion body mindset? It's very sad. No, you should never do that. Then why are you clinician? No, clinician department can be closed then. So you should make the diagnosis and then choose the correct issue to be analyzed, and then you will get the diagnosis. This is not inclusion body mindset. Any questions are there? No. Over, huh? Over, huh? Closed, huh?
Ma'am, there are no questions, ma'am, in the chat.
Okay.
Yes, ma'am.
This is CIDP, not inclusion body mindset. Certainly do a sural nerve biopsy and send it to them.
Okay, ma'am.
Okay.
Yes. Shall we close?
Yes, ma'am. It was
Thank you,
indeed a
ma'am.
very comprehensive clinical class. Thank you so much, Professor Chandra, ma'am, for the wonderful explanation and the detailed discussion, ma'am. We could learn a lot
Clinicians
from
feel
you.
important. You see, you are clinician, no? You are not a radiologist, you are not a pathologist. Feel important. You are the most important person to the patient, because physical, mental, social, spiritual well-being you can give to your patient. So do not consider yourself inferior and act like a executory apparatus who will execute the diagnosis given by the radiologist or any other person. That means you are not respecting your own speciality. Don't ever feel like that. That is a very unfortunate and a very wrong trend young people are having. You do not understand. You are underestimating your role in patient care. You are the most important person. If you remember that, you will know that medicine is much, much, much more than anything that purchasable comfort that medicine gives you. It will give you a lot of unpurchasable things for which you should understand you are a very important person. You should be confident in your subject, read properly, make a proper diagnosis, and request the pathologist or radiologist or anybody to help you. Instead, many things are there which are labeled as incidental changes. You will have an incidental meningioma and patient will have pseudo seizures. So you will think it's a true seizure. No, they are all called incidentalomas. Incidentally, some atrophy will be there, some fatty infiltration will be there, some inflammatory cell will be there in a 68-year-old man. That is not inclusion body myositis. So they are all called incidental changes. They have no relevance to the patient's disease. So you are the most important person. Feel proud of yourself. You think that you touch lives with your heart and your soul and your brain. And feel very proud. Update yourself properly. Have a clear information about what you are dealing with. Then you will understand at the end of your journey through world, you would have changed many lives with the help of Almighty. Almighty has to help you, otherwise it will not happen. Almighty has to choose you as an instrument, provided you do your work properly. So thank you.
Thank
Shall
you
we
so
close?
much, ma'am.
Yes.
Thank you so much, ma'am. It was indeed a very comprehensive clinical class. And thank you for guiding us, ma'am. We could learn a lot from you. And we could
Thank
learn
you.
how to be a clinician from you.
Yes.
Thank you so much.
Very important, no?
Yes, ma'am.
Very good. Thank you.
Thank you, ma'am. It was a great effort by Dr. Priyanka, ma'am. We could gather a
Yes.
lot of points
Good,
from
good,
your
good.
presentation.
Good.
Thank you, ma'am.
Very good.
I
Thank you,
thank
ma'am.
all the participants for their active listening and participation. Thank you, one and all.
Thank you. Okay.